Tuesday morning, 11 a.m., Stroke Buddies, Stroke Survivor Support Group meeting. Gosh, we've never had a doctor and we've never had a neurologist until a couple weeks ago when Dr. Mark McDonald appeared and told us a little bit about why he became a neurologist, his journey to Centrillo, the company that he is CEO of that is trying to help us all with stroke recovery information and preventing a second stroke. And he agreed to come back this week as a neurologist, and I titled it Ask a Neurologist. And look at the response. I got both in the groups and it showed up today. Obviously, this is something that's important to a lot of stroke survivors. So thank you, Dr. McDonald, for agreeing to try and answer some of our basic questions. And I thought maybe the place to start is, I think there's some confusion in the stroke survivor community as to what a neurologist is, what they do, and how they fit into the whole thing with with somebody's PCP and therapist and that sort of thing. So I'd be curious to just have you give us the basics from your perspective on what neurologists do in relation to stroke. I know from taking patients that some neurologists specialize in stroke and others don't know that much about it. They're more into other things. So might be important to look for a neurologist that practices in the stroke realm. Okay, Ralph, you be quiet now. You let Dr. McDonald talk.
So definitely a common question. What is a neurologist? I think there's a lot of confusion with what a neurologist is versus what a neurosurgeon is. So a neurologist is in a way like an internal medicine doctor. So we are a group of doctors, including internal medicine, who primarily focus on diagnosing disease and managing the disease with medications and other interventions. We do not actively do a lot of surgery. We're not surgeons. And we are more on the kind of diagnosis and day-to-day management side. Now for stroke, which is one of the big areas in neurology, there's a lot of different roles that I'll go into. I'll probably just stay with the overall framework of what a neurologist is and then move into stroke and specifically. But neurologist probably has the most involvement with stroke of any other doctor, really should have the most involvement in terms of the multiple touch points. So the big areas in neurology are stroke, epilepsy or seizures, multiple sclerosis, Parkinson's, Alzheimer's, headaches. Those are kind of the big categories. You can specialize in stroke. Some doctors don't do a specialty, or they just finish their residency and go on to practice. I've spent the last 10 years studying stroke technology and researching stroke technology. I did not do my clinical training in stroke after I actually did it in multiple sclerosis. But we have a lot of good systems in place for multiple sclerosis that I want to bring into stroke world, because most of my patients that I see on a daily basis are actually stroke patients. So I do practice telestroke still, even despite the founding the startup and building the startup. I do a lot of telestroke and very active in those hospitals that managing stroke patients. And so 85% of my practice is with stroke patients, and most of my research the last decade has been with stroke, but I didn't do any formal training after residency. And part of that is that we get a lot of stroke training in residency, but definitely at some point in time, Ralph, I want to connect you to Dr. Benjamin Coomer, who works with Centrillo, who's a dedicated vascular neurologist or stroke neurologist. and he can come on the show. And Ben knows more about stroke than I do. So,
Wow.
I will, I'll keep that with a grain of salt. I mean, I know I have written a lot of papers on stroke. I see a lot of stroke patients still, but mainly on the inpatient side. I haven't been as involved in clinic. But I am a neurologist and can kind of speak to what I've seen and what I believe is really the path forward for neurology and stroke. Any questions about a neurologist at a very high level? Happy to answer that before we kind of get into the details.
I would just say that your information and knowledge about stroke, our knowledge and information about stroke pales in comparison to yours. So whether you did your residency in stroke or not, you've been studying it for 10 years, and you certainly are an expert to everyone here in this meeting.
Oh, thanks, Rob. I appreciate that. And so, yeah, I'll if there are no questions about that. So let me talk a little bit about where stroke neurologists, or where neurologists in general fits in with stroke. And so, there's really three phases to stroke from a clinician standpoint. So there's, and arguably there should be four, but let's just talk about three for now. So there's the, oh my gosh, something's wrong. I don't necessarily know what it is, or I know what it is. And I think it's a stroke, but we got to do something. We got to go to the hospital, or we got to see our primary care doctor, or sometimes, and this happens more than you would like. A family member says, "Oh, something's been off the last couple of days," or the primary care doctor notices, "Oh, wow, something's been off. We need to get you to the hospital." But we call it sort of the acute stroke setting, or it's really the days or weeks when somebody's had a stroke or some sort of event, and they come into the hospital for the first time, and we call that sort of the inpatient stroke or acute stroke. And so that's where the neurologist is very much featured. I would say probably 15 years ago, you had a lot of internal medicine doctors, or primary care doctors, or ER doctors that were involved there. With the advent of telemedicine, you're more likely than not going to see a neurologist, whether it's in person or through video conferencing. And so that increasingly is becoming the domain for neurology. So you come into the hospital, you or a loved one, you're having symptoms of stroke, and they're going to call a stroke alert. And so what that is that's a kind of well-defined set of responses. So they are going to call a certain nurses to come help out. You're aiming to get a CT done in a certain amount of time. You're aiming to get a neurologist on screen or in person in a certain amount of time. And there, it's all about, what can we do for this patient now? What can we do? Can we give clot-busting medicine? So you're all probably familiar with TPA, tissue plasminogen activator. There's a new drug called tenecteplase that's very similar to TPA. That's probably a little bit better. Thrombectomy is increasingly used. And then there's supportive management like blood pressure management. If somebody's had a hemorrhage, there's certain things we can do, even though that's more in the neurosurgery space. So the neurologist is really the first person to see a patient and say, I think that this person is having a stroke, or I think this person is having a migraine, or I think this person's having a seizure, and we have to do X, Y, and Z. And sometimes that means we have to, I think this person's having a stroke. We need to call the surgeon to come in and take the clot out. So sometimes we'll bring in another expert to help with that treatment plan, but ultimately we create the treatment plan. So if you have a stroke and you go to the hospital, in most places, the neurologist will be the one who makes the final decision about what you have, what you probably have, and what treatment you should get in the first 24 hours. And that's typically the case. Now it really starts to change from there. So ideally, you want a neurologist to then be involved while you're in the hospital. And one of the big things that I tell my patients after I see them on day one versus day two, what I tell people on day two is that, you had your stroke, you either got the treatments or you didn't get the treatments. Our focus now is to understand why the stroke happened so that we can try to prevent a future stroke. And so the risk of recurrent stroke, based on one of the largest registries in Europe, is about 30% in the first 5 years. That statistic is different depending on the different papers. I've seen as much as 50% in 10 years. So the first year is about 13%, but the risk of recurrent stroke can be high. And part of that is people that I don't want to scare people here. I think there's most, if you're here, you're probably somebody who's more committed to doing the things you need to do to not have a stroke. So I think those statistics factor in people that have completely checked out, or factored in people that have some kind of rare clotting disorder, some other things. So I wouldn't necessarily think that applies to you, but the reality is the risk of stroke is high. And the goal of a neurologist day 2 onward is to say, why did this person have a stroke? And we have a few tools to do that. So if you look at the big categories of stroke, it's changing, but there's really 4. So there's large vessel. So that means did you have a plaque in the bigger arteries, so the carotid arteries, basilar artery, so that's the big one in the back. There's small vessel, so did you have a small kind of branching arterioles that clotted off? There's cardioembolic, so that's, did you have a clot travel from the heart to the brain? And then there's kind of an other category that has unique things like hypercoagulated state, which is just a fancy term for someone who is more likely to clot. There's dissections, so the vessel wall rips. And then the other category, kind of aside from that, is cryptogenic, which means we really have no idea. And it sounds like a meaningless term, but it's important from a research standpoint. It's important for a treatment standpoint. And so it's good to, if you're truly cryptogenic, if that's the diagnosis 4 days out, then that means something different than if you're in the other category, or if you have large vessel or small vessel or cardioembolic. And so the job of a neurologist in the hospital is to be pretty damn sure that this person either has this or likely has this. And if I don't know if they have this, then they need to do X, Y, and Z to figure it out. Because the only way that you can prevent future stroke is to understand why the first one happened. And one of the things that we know, based on years of research, is that if you correctly identify why someone had a stroke and you put them on the right preventative care, then you can reduce their risk of stroke by 80%. And so you think about that 30% number, in 5 years, if you don't do anything, well, you can greatly reduce that if we know why you had your stroke and you just stick to the things that the doctor tells you to do. Now that is sort of where I see the biggest breakdown in care, because what's supposed to happen is, day 1, you come into the hospital, they make a decision about whether you have a stroke or not, what treatments you need. And then before you leave the hospital, the neurologist either knows why you had the stroke, or they have a plan to figure out why you had the stroke. Now, sometimes they send you out of the hospital with a plan to figure out why you had a stroke. And then what we know from just large studies is that about 40% of people never see a neurologist again when they leave the hospital. And most people that see a neurologist only see them once. And so did you have a 30-day cardiac monitor if you to look for atrial fibrillation? Did they look at your blood vessels to see if you've got narrowing of the arteries in the neck? Did we do all the things we were supposed to do? And then beyond that, are you on the medicines that you're supposed to be on based on that stroke mechanism to prevent future stroke? And did the doctor actually do a good job explaining why you need to be on your statin instead of just saying that you need to be on it because of cholesterol? Because the worst thing that happens is doctors say, oh, this is an anti-cholesterol, or this is a cholesterol medicine, and you have a great cholesterol, and they don't explain why it's important to be on a statin. despite having a great cholesterol level, which is unfortunately, and we talked about this last time. I don't want to make this a discussion about statins. There's some anti-inflammatory things there. There's some things you could probably do with diet. And I'm not saying that everyone has to be on medicines. There's obviously certain lifestyle things you could do that probably would make you not need medicines. But the reality is, in that first stage, if the doctor doesn't know you, if they don't know whether you're going to be committed to lifestyle changes or whether they're going to be able to achieve things with behavioral interventions, the recommendations from the society, from neurologist societies, they're the biggest one. The one we follow is the American Heart Association, has the best evidence-based guidelines, is to be on these drugs if you have these conditions or you have these mechanisms. And so that's really the role of the neurologist when you leave the hospital, is to make sure that they're confident and they know why you had your stroke, and they're confident and that this is the plan to make sure you don't have another one. Now, where the neurologist could play a bigger role and doesn't, in my opinion, is they could be also a leader in your rehabilitation. So one of the things that we see in stroke clinic is, the patient comes in and, we're reviewing the imaging. We're trying to decide, did we get it right? Did we know why they had their stroke? We look at their medicines. And then as sort of an afterthought, we're like, how are you doing? Are you walking? Do you have what you need? Do you go to therapy? And the reality is, so much of what my patients need is not necessarily, did you take your aspirin or not, but how are you feeling just with yourself? How's your confidence? How are you sleeping? How's your fatigue? How are you able to do some of the things that you love doing again in the next 6 months? And so in multiple sclerosis, we did a much better job of having multidisciplinary clinics where people would come into the clinic. You'd have a physical therapist there, an occupational therapist there, a cognitive psychologist there, and then everyone would make a decision by the end of the day of, we got to do X, Y, and Z to help this person. And that's something that I think would help with stroke a lot. It may be happening at certain academic centers around the country, but it wasn't happening at University of Virginia and other places where I trained. And for the most part, the neurologist was not really involved in rehab or recovery or just overall wellness. It was, and the reason I think that that's the case is because we as a medical community still think stroke is a one-time deal. We treat it like it's like you had the flu, and now it's gone. Multiple sclerosis is obviously a lifelong disease. So it's easier for us to think about, okay, I need to become an expert in diet and cognition and all these things to help this person, because the goal of the medicines is to help them function better and not have relapse and not decline. And the medical community it still treats stroke like it's different from that. And it's not different from, it's not the same thing as multiple sclerosis. It's not your immune system.
I'm low down here.
So
what's the trigger point
but
that tells Northside to go winterize?
is that,
So
that's not me.
maybe we're giving every home bacon.
Can the admin go ahead and ask people to mute themselves so we don't have this happen again?
Yeah, it took me a second to mute her.
I think obviously that stroke is different from multiple sclerosis. It's not the brain attacking itself, but if you look at the risk of recurrence in stroke, and you look at all the challenges that people face after stroke, we really need to treat it like a chronic disease. And I don't think the medical community has done that. And part of the reason I personally believe, and I'm not trying to get into conspiracy theories, is financial. I think that does play a role. I think there's plenty of good doctors out there at academic centers that are doing the right things. But the hospital administrators, they see the money in the MS drugs, and the reimbursement makes sense to have an infusion center, to have all your MS patients here, and there's not the same type of investment with stroke. And so I think that it's a combination of outdated thinking and then also follow the money that sort of contributed to this archaic model of stroke care. And so where I see the future is potentially using telemedicine and even artificial intelligence to make it where stroke survivors can get the expertise of neurologists, of neuropsychologists, physical therapists, occupational therapists, speech language pathologists, and that knowledge can be integrated and accessible week to week, not like every 6 months or never. And so I think that that's one place that technology platforms can take it. But even just having a multidisciplinary clinic and having a neurologist that you see regularly because stroke behaves like a chronic disease, I think would be a vast improvement from where we are now. And the reason why I think a neurologist is important is, they are the ones who understand all of where the research is. They know why it's important for someone to be on an anticoagulation or some sort of anticoagulant with cryptogenic stroke because they're aware of the different trials going on. They know the up-to-date guidelines for lipid management, for X, Y, and Z intervention. And so it's important for neurologists to be more involved, arguably be involved before you have your stroke, because they understand how to monitor for certain conditions and how to manage risk factors better than primary care doctors. So I think that we need a way to kind of get that expertise out there and then just change the whole model. But I don't want to go into a rant of where I think neurology could be better. I want to make sure that I'm available for you all and answering your questions about what a neurologist does. So
one thing you mentioned that typically people only see a neurologist once or twice. I guess I saw mine in the hospital, and then I went for a follow-up, and they did a second CAT scan, said everything was healed, you're released. Well, I took 17 questions, and he answered all of them. And when I was done, he asked me if I had any others, and I said, what does released mean? He said, it means I don't need to see you anymore. I said, what if I need to see you? And he said, well, then I'll keep seeing you. I'd like to think that most neurologists had that same kind of attitude, towards continuing to see a patient who wanted to be seen, because, frankly, my neurologist, I saw him 4 or 5 more times, and he was invaluable in terms of educating me about stroke in general and my stroke and what I was going to be dealing with specifically. So I would hope that was the case. Might suggest to people that, you don't have to be released. I'd be curious about your thoughts on that. And also, what can we do to help with the whole diagnosis thing? I think most people have a stroke, go to the doctor, and they don't interact much. They're just there. They'll answer questions. I don't know if there is anything that we could do, but I'd be interested in your thoughts on how can we get to the bottom of work with you better to get to the bottom of our strokes. And do you think most neurologists will continue to see you if you want to see them?
Yeah, that's a great question. I mean, I think that most neurologists will continue to see you. I do think if you can articulate your needs to a neurologist on a case-by-case basis, most places, if you're lucky enough to get that outpatient appointment and see them, they'll keep seeing you. It's because I think the neurologist wants to help you, and it's more of the administrators that are thinking about staffing needs and how much support do we need for clinic. They're the ones that are deciding, okay, well, we have this many strokes in the hospital, they need to see a neurologist once, and then they don't need to see him again. And so I think on an individual basis, you could probably push for your neurologist to see you again, as long as you are equipped with the arguments that they're going to kind of work with them. And that's a big part of what I do for friends and family is just tell them, okay, say this line, and then they'll do this or they'll do that. I mean, you kind of have to manipulate the system a little bit. And what I would say for you all to tell your neurologist is that you want ongoing support, that you're doing the right things to prevent future stroke, that you are being educated about new research, and that they're able to kind of monitor your other needs and help organize support services for you. And just say that you have a lot of needs, and that you're the best resource for me that I have access to. And most neurologists aren't going to turn you down. I mean, they're not going to tell you to go away. So I think that that's really important. But also you need to make sure that you have a doctor that you can get in with and see regularly. And if sometimes a great primary care doctor would be better than a bad neurologist. Accessibility is a huge thing.
A 1-2 punch would be the best, especially if they, work together at all, which doesn't happen so much anymore. But
yeah. And then the other question about what can I do to make sure that they did all the right things? You really have to, this is where it gets really tricky, because you kind of have to make a decision about without knowing what all the things are supposed to be. You kind of have to make a decision about the quality of the hospital. And so if you were at a academic center, so if you're at medical college or MUSC, if you're at the Medical University of South Carolina, University of Virginia, if you're at Duke or any of these other places, if you're in an academic center, you just follow their lead. It's pretty unlikely that they're gonna have not gotten an MRI or not made a diagnosis about why you had your stroke. The problem is when you're talking about other hospitals. So the way that I would, there's a few things that you could do. You need to make sure that you had an MRI. And the MRI doesn't necessarily say, the reason for the MRI is not necessarily to show, okay, this is why I had my stroke. But because you can potentially see a stroke on the CT scan. The MRI, what that really helps with is it shows that it can show, okay, I had a stroke in multiple areas, or I had a stroke in this one specific area, and it is the best tool we have or it's one of the better tools to tell us why you had your stroke. So if you didn't get an MRI in the hospital and you don't have metal in your body, then somebody probably messed up. So there's a couple of rules like this. And actually, Ralph, if people are interested, we can put together kind of a list of rules cool. Like this if people are interested. So I think the first thing is, did you get an MRI? And if you don't have a reason not to get an MRI, I can't think of a case where an MRI would be the wrong thing. MRI is always going to be helpful. The second thing is, did you have some sort of vessel imaging? And that can be a little bit tricky because you don't always, it's hard to know what the tests mean, but did you have a CTA or CT angiogram, or did you have an MRA or an MR angiogram? The other thing that people do to check the vessels is, did you have a carotid ultrasound? So if you look at your paperwork and you don't see that they did any one of those things, we'll say probably messed up. So that would be the other thing. Every patient should have a lipid panel done after they've had a stroke. So you should know what your LDL is, what your HDL is, what your total cholesterol is. They should have a hemoglobin A1C done, which is just a fancy blood marker for looking for diabetes. Every patient should have an echo, which is just an ultrasound of the heart. And if we don't know why you had your stroke, every patient should be checked for atrial fibrillation. And so, it can be tough a year out or 2 years out. But oftentimes you can get the discharge summary and that will include the test. And so I would look and see, did you have an MRI or not? Did you have some sort of vessel imaging or not? Did you have an ultrasound and did you have these labs? Now, that's a lot of work for you all to do kind of on your own. So I think that let's think of all the little tricks you can do to prevent you doing all that work. So were you at academic center? Well, they probably did all that stuff. Did you see a neurologist after the hospital? If you did, then they probably checked all that stuff and did all that stuff. And so I think the people that really need to dive into the paperwork are the people that didn't see a neurologist when they left the hospital and they weren't at an academic center.
Well, we all need to come to you because lots of us, I got a CAT scan, period, no other kinds of imaging. You see a lot of discussion about hemorrhagic strokes, whether they can be seen with a CAT scan versus an MRI. I had ended up having an MRI later over some neck loading, and it was very revealing. It showed that I hadn't had any more strokes. Apparently, past infarcts, past insults show up as dark spots, and that you can tell if you've had any more. Of course, you can't tell anything if you don't do any baseline imaging. If you can't come in like in year 5 and take an image, and if you don't have anything to compare it to, it doesn't mean that much to you. But I think everybody in this group would absolutely agree that stroke is a lifetime event. I think that everybody here is concerned about educating themselves. We understand that we have to advocate for ourselves or we don't get what we need. So, adding a neurologist to the list of learning how to navigate the healthcare system, learning how to interact with your PT, learning how to be your best patient advocate and PT. It's a lot to dump on all of us, but we all here at least understand that if you don't do that, you don't get what you want. And some of us here, or a lot of us here, preach that to other people so that they can get what they want.
And Ralph, I have a call at 12, so I want to make sure that other people are able to ask questions.
Yeah, I want to make sure too, because I can ask questions for 5 hours that you don't have, but it's also important to let other people ask. So Sandy, did you think?
Yeah, I'd like to ask a question. I'd
Okay.
like to make a statement about the whole thing. I did see a neurologist in the hospital. I saw a vascular surgeon when I left. I had a young primary care doctor did not want to give me Plavix. And so that kind of set me off thinking, I might one day have to prove I even had a stroke. So I picked up all my records from the hospital and I was shocked. Nobody told me I had plaque throughout my brain, extensive plaque, and all I can see is another worse stroke coming. So I made dramatic lifestyle changes based on that. If somebody had told me that, nobody told me that. And so when I had my stroke, I was on keto diet. Wrong thing to do. I had a 300 cholesterol. And so I made dramatic changes in my diet. I take the cholesterol medicine, but somebody really should have gone over that with me because I did not realize how drastic, what a drastic amount of cholesterol or plaque I had in my brain, all over my brain.
Yeah.
So anyway.
No, that's great. And good for you, Sandy, for doing that and taking the initiative. Yeah.
Well, it sounds like I said earlier, the neurologist is kind of the point person. You get. I know some neurosurgeons, and they're highly focused on the interventions that they specialize in, whatever they are. So I think that we're back to what Dr. McDonald said. That basically everybody should see a neurologist. Unfortunately, our insurance doesn't treat a stroke the same way it does MS. I think it ought to be declared a lifetime event, but good luck, Ralph, getting insurance companies to go along with you because that's going to cost some money. Maybe there's a way to figure out how to copy the MS model over into stroke so we can get what we want. I've been working on that in my mind ever since you said that a couple weeks ago, Dr. McDonald, but it's a tough one.
Yeah.
I
See,
do want to say this, when I went back to the vascular surgeon last week, my lifestyle changes. He said, I can't operate on your carotid artery. You're not bad enough. It's regressed.
yeah.
So that was dramatic.
Yeah, that's fantastic. No, I think that that's a great story. And I think what it points out, Sandy, for everyone else is other than, the benefits of taking initiative, but that's a great example of somebody when you have intracranial atherosclerosis, you have atherosclerosis everywhere. We know exactly what that person needs to be on for a while. So that person really should be on dual antiplatelet therapy, aspirin, Plavix for 3 months. And then afterwards, I think it's a case by case, whether you're on an aspirin or Plavix, it could just be one of them. And then like you said, you follow up with your vascular surgeon and you don't necessarily have to have surgery if you're doing all the lifestyle things. But I think you were lucky enough to kind of, or not lucky enough, but you took the initiative kind of, you were smart enough to kind of pick the right path by yourself. But really it should be somebody telling you, okay, you got to do this for 3 months. You got to see these people. And then this is our game plan for the next 6 or 9 months. It sounds like you never really had that.
Well, and it's great to hear that lifestyle changes can make that dramatic of a difference. So I would say, do what Dr. McDonald suggests, and if you have cholesterol or lipid issues, take the medication until you can, educate yourself, start making the changes, see the changes. Most people out there sit back and they think that the next thing up for them is getting their carotids roto-rooted. They don't think about lifestyle changes. And so I think it's great that you're able to make that. And I bet Angelia does too. So let's see, anybody else? I mean, I got a list of questions here, but okay, Abraham. Okay, and I see. Michael, were you putting your hand up too?
Yes.
Okay, we'll get to you next. Abraham, then Michael.
I noticed that you've been talking a lot about like cholesterol and plaque in the arteries and whatnot that would cause stroke. But what about other causes of stroke? Because mine has nothing to do with cholesterol. I was 17. I don't think I even had a chance to.
Yeah, I mean, so I do think that if you're younger and you have your stroke, a lot of that's going to be just fluke things. So you're going to see.
But no one ever tried to figure it out. No one asked me questions about like my lifestyle, like what occurred leading up to this, or what, like precursors or anything that would conclude to what happened. And I've been kind of floating around for almost 30 years now, wondering, was it so I'm guessing it was some sort of concussion, like I hit my head, because I had a couple bad accidents doing stuff, but
it's hard to say. And I think one of the problems is they didn't have a lot of the tools that back then that we have now, which I think is.
I know they don't. And I live in Maine, so like our biggest city surgeon is like your rural city surgeon. So
yeah,
there's that.
I will say that a lot of the causes, I mean, I don't want to, I'm really not in a position to give medical advice, but I think in my experience, the causes of stroke when you're 17 or in your 20s, if you haven't had a stroke for years, then those probably aren't going to be at play anymore. And the most common causes are going to be vessel abnormalities, bleeds, clotting states, tears in the wall, which can happen. You can get a dissection. And unless you have a vessel abnormality, that is just a fluke thing that shouldn't happen again. There's some people that have.
I haven't really ever worried about it happening again. Like I know like people have issues like sleeping and stuff because they're so worried about it. But like, I don't ever recall having an issue like I was worried about it happening again.
Some people don't need to worry about it again as long as you know why it happened. I think is the biggest thing. And if it's been that long for you and you don't know why it happened, it's probably okay. So.
Well, I'm sure it's okay, but I'd still like to know.
Michael, you had a question?
Yeah, I had a question. I'm actually 60, and I had my stroke as a result of AFib.
Yeah.
I got chased by a pit bull and subsequently had a stroke. I wanted to know what are the best ways at a high level to manage risk and recovery of the stroke at a high level in general. And I wasn't on Eliquis at the time. I'm on Eliquis now for the AFib. I was on Eliquis about a year and a half before the stroke, and they took me off of it. And they believe that my AFib contributed to my stroke.
Yeah.
So I'm just interested in managing risk of subsequent stroke and aiding the recovery process of the stroke. I physically run about an hour a day trying to get better.
Yeah.
Thanks.
That's great. Yeah. I mean, I think being on Eliquis is my favorite drug for AFib. I don't get any money from the drug companies. The reason why we like Eliquis, or we did at University of Virginia, is because we feel like the pharmacokinetics are better than Xarelto and some of the other medicines. And it's a lot better than Coumadin or warfarin because the bleeding risk is lower, and people on Coumadin they're out of range about a third of the time. They're either too high or too low. So Eliquis is a great drug. So, I mean, you're already doing one of the most important things you could do. I would say for atrial fibrillation, one of the big things that you probably need to look at, or if you haven't already, is do you have underlying sleep apnea? That actually contributes a lot to atrial fibrillation, and treating that will help reduce the burden of atrial fibrillation. And it's kind of a numbers game. You don't want to be flipping in and out of AFib too often. And so if you can reduce the burden of atrial fibrillation, that's kind of where you can control it. But running is great. I think being on Eliquis is great. I mean, you're doing the things that's going to help you out the most. If you snore at night, if you wake up a lot at night, if you feel sleepy a lot, one of the things that you could do is talk to a primary care doctor about, have you ever had or have you ever been tested for sleep apnea? Are there any concerns for that? And if you don't have any of the features of sleep apnea, that's not anything that you need to worry about. And I'm not saying that you need to go talk to your doctor. This is just in general for people that have had stroke from AFib. Make sure you get on a blood thinner. That's huge. And then I think the second thing is what can you do to kind of reduce the burden of AFib is the next thing. And so that's exercise is great. The fact that you're exercising and just living healthy is one of the biggest things you can do.
Yeah, I don't have any difficulty sleeping. I normally sleep through the night. I don't know if I snore or not, but I normally sleep 7 hours usually at night, to my knowledge.
Yeah, and I'm not saying you have it or you need to go get checked for it, but that just in general that you want to make sure that you're eating healthy, you're working out, you're taking your blood thinner. And the only other thing that I would say is that just reading about sleep apnea or talking to your primary care doctor about sleep apnea would be the last. That's kind of the thing that most people don't know, because that contributes to atrial fibrillation. So.
Okay, looks like we got 3 people with their hands up. Courtney had hers up first. So you got to unmute yourself. There you go. Go ahead.
Hey, doctor. We appreciate you being on this call today. My question is, I had a stroke last year. It was in the basal ganglia area, and it was undetermined etiology. And so far, there's been no known cause other than it was a blood clot that we don't know where it came from or why. I had no underlying health issues prior, and I'm currently on just Plavix. And I guess my question is, what are the chances of coming off of Plavix, or is that something that I should just totally forget about? I'm probably going to be on it for the rest of my life.
Yeah, I would say that And did you see a neurologist when you left the hospital?
Yeah, I went to a medical school, one of the higher
Great,
up schools
great.
here.
Yeah. Yeah.
They ran every test in the book. You know, I've had the esophageal echo done. I've had MRIs. I've had everything you talked about, basically all the blood panels. They said that I didn't need to be on any sort of statin drug. So I'm the picture of health otherwise. So.
Yeah. So I guess, you know, other than checking back in with them a few years from now, it's one of those those cases where sometimes we don't know. I mean, 20 years from now, I think we'll say, oh, we had this blood test we could have done that we could have figured out these people. The main thing is, I would say you probably do need to be on Plavix. Especially if we don't know why you had it and where the location of the stroke, basal ganglia. Most of the time, those are going to be from small vessel disease, and that's things like high blood pressure, which you probably don't have, and some of the other stuff.
No, I actually have on the lower end of blood pressure because they tried me on some sort of medication to try to control my heart rhythm because I guess I developed some sort of AFib just briefly after my stroke, but I didn't have it before and I don't have it now. And when they started me on, I forget it might have been some sort of Eliquis or something of that sort. But it made my blood pressure drop way too low because I already have like 90s over 60s or barely hundreds over 70s.
I think it's one of those things where the risk benefit is such that you should probably just keep taking the Plavix. That those drugs are pretty effective, aspirin or Plavix, and we don't totally understand why. So and then the other thing is just making sure you're monitoring for things to pop up. So that you're looking for atrial fibrillation, that you have, there's going to be tools. I mean, Apple Watch is getting better. That can do it. You can start to use that, but looking for things. Oh, perfect.
That was my first purchase.
Yeah. We're it's Centrillo. We're going to start looking at things like heart rate variability and blood pressure variability as some biomarkers for people that otherwise don't have risk factors.
Well, if you need a study, I'll gladly be a patient to help do a research on.
Okay. Well, yeah, no, we're going to be doing a study coming up here in Virginia. So I'll definitely, I don't want you to have to drive too far, but we'll keep people in mind. And I don't want this to be a plug for our research study by any means. But yeah, I mean, I think that, Courtney, that's probably one of those situations where, just do what you know to do. And the good news is if they haven't found a cause, then it's probably more likely that it was a one-time thing. Sometimes we see migraine stroke, and that's just a fluke thing that happens. Is a rare side effect of migraine. It's usually in older women who smoke, but that's something that we've seen before. I know that's not reassuring to tell you, but I think that the fact that you went to a medical place, that they did all the tests, that you're monitoring for AFib, that you're taking care of yourself, you're taking your Plavix. I mean, you got a lot of your bases covered. So.
All right. Thank you. I appreciate it.
Okay, real quick, I noticed that Elba and Polly both had their hands up, and now we have Julie and Martha, and Dr. McDonald's going to turn into a pumpkin. So what I'll do is, I don't know whether Elba or Polly is next.
Elba's on. So
okay, go ahead, and then
question.
Julie and Martha, and anybody who doesn't get to ask a question, I'll write them down, and we'll see if we can't get you basic answers. So go.
My question's just a basic question of I did all the testing. I have a zillion doctors, but mine was all caused from blood pressure, which is still constantly going out of whack. In your opinion, who's the best? Do I go to my cardiologist? Do I go to my internist? Do I go to my neurologist? Do I go to there's so many, I just need somebody to help me get this blood pressure under control.
Yeah, you're the best doctor for you is going to be the doctor you can get into as regularly as you can. That's going to listen to you and work with you, because blood pressure, it's all trial and error. I mean,
I know.
it's a lot of tweaking this, tweaking that. And so whoever's going to be the most accessible of the people you listed and who's going to take it seriously. But yeah, that's a huge thing, and getting that under control is going to be critical. So and if you're primary care, I mean, I would say typically it's going to be your primary care doctor. Cardiology can do that. They don't like to do that, but they can for rare cases. And if your primary care doctor is not doing their job, then you may want to look for another one.
Yeah, that's the hard thing. That's the hard
It's
part.
very tough. It's very tough.
Very tough.
But I would say, the one thing that you can do for your doctor is you kind of take the initiative, and I'm not saying you're not doing this, but just in general, you take the initiative to get really good readings on a regular basis, and so that they have all the data they need to make better tweaks quicker. One of the problems we see is that people aren't measuring their blood pressure at cuff or measuring their blood pressure at home. They're not checking their cuff in clinic. They're not always taking their medicines, and so one of the things we see is when people would start taking all their medicines, their pressure just drops. And then so I think the first step is finding a good primary care doctor that's accessible, and then making sure that you're giving them all the data they need to make the right decision fast. So.
Okay, great. Interesting answer. Find the most accessible doctor. Interesting. Okay, Polly, let's see if we got time for yours, and I think I need to let you go, Dr. McDonald. And since then, we've had James and Jeff also. I'll stick around and take questions. So I'm taking Polly's time. Go, Polly.
Hi, Dr. McDonald.
Hey,
I
Bob.
want to know how to find a neurologist that specializes with stroke. I have a neurologist that I see regularly, but he specializes in Parkinson's. So he's not of much use to me right now.
Yeah. So I think the best opportunity would be looking at the academic centers, and trying to get into here in Virginia. I would say University of Virginia or VCU or Georgetown are kind of the places. Any different state, the academic centers. And the reason I say that is because you're really looking for somebody who has a robust stroke clinic. And oftentimes at some of the private hospitals, they have a stroke follow-up clinic, but they don't have a big stroke clinic. And the stroke doctors there are really just seeing patients in the hospital. So I would try to get find an academic center. If you have a doctor that is in your family, it could be like your cousin's housekeeper's uncle. I mean, it really could be anyone. But if you can find a way to get a doctor to be an advocate for you, they're going to help you get meeting in the next 4 weeks rather than the next 6 months. Having a doctor that you can call and help you with appointments, it's just an incredible cheat code. I highly recommend if you have anyone that any doctor you can kind of get in your corner to help you make a faster appointment. I don't know what it is, and it's a problem with the system that you need that. But a big part of what I do for my friends and family is just help them get earlier appointments. Just you know what to say, you know how to do it, you know what strings to pull. And so I would say find someone that can be your advocate, and target the medical centers, the academic centers in your area.
I get them to put me on the cancellation list, and then I call every Monday. If you call too often, they'll get irritated with you. If you don't call often enough, you'll drop off the cancellation list. You'd be surprised. I mean, I've asked at 10 o'clock in the morning at MUSC one day, and they called me at 1 and said, "Can you be here at 2?" Same day. Well, it's longer drive than an hour, but you'd be surprised what a cancellation list and working it. Will do. So I think we need to let you go. I'm going to continue to record their questions, and I can point you to it in the recording. If
And
you,
Ralph, I'm happy to make some time. It's not on a regular Tuesday, but if the group wants just to have like a 20 or 30-minute Q&A, just, you know, we'll go right to the quick Q&A. I'm happy to do that for everyone. I feel bad that we couldn't get to all the questions.
well, you were here an hour and a half last time, so we know it's a matter that you're generous with your time. It's a matter of you're a busy guy. I mean, you know, come on. Doing telestroke, rounds, hospital stuff, research, CEO. You know, I thought I was busy. Anyway, we appreciate you, and yeah, we could look into that. I'm going to have some things that are not going to happen on Tuesday because they involve a neuro PT in England, and he's got some interesting things to say and just can't do Tuesdays. So we'll let you go. You have a great day, and know that everybody here really appreciates you taking the time to share your knowledge and expertise with us.
Yeah, it's been a pleasure. I love this group of people. I think we had a great time the last call, and I think very highly of the Stroke Buddies group. So we'll stay connected, and yeah, I'd love to be on again.
All right. Well,
Thank you, Mark. Have a great day.
Yep. Thank you.
Take care.